I request our chairperson to call other speaker for on the dais.
I invite Dr. Monika Bawa.
We have some issue of mic, so please I request all the faculty members and chairperson to speak loudly.
Good morning, everyone. Am I audible or I need to speak a little more louder? Thank you. So to start the session today, we'll start with the surgical causes in the pediatric age group. I think a lot of discussion must have happened in the adult patients, but hardly anything must have been discussed about the pediatric patients. I saw the brochure and it there was just one talk on the pediatric group. So as we all know, the causes of surgical jaundice in pediatric age group are absolutely different from those in the adults. Any jaundice which persists for more than 2 to 3 weeks after birth needs evaluation because it's not the physiological jaundice and it's not the unconjugated jaundice which is going to persist for that long. So we have to differentiate from the unconjugated form and work up on the lines of neonatal cholestasis syndrome. So the most common causes for neonatal cholestasis, I would just brief on the obstructive causes, which include biliary atresia being the most common cause, followed by choledochal cyst, bile duct hypoplasia, inspissated bile duct syndrome, and idiopathic perforation of the bile ducts. So the history taking in the pediatric age group is different from the adults. I will keep saying this sentence because our patients are absolutely different from the adults, although the management ultimately is the same in all the age groups, but the presentation, the history taking is absolutely different. So we need to take the history of torch infections in the mother, along with history of diabetes mellitus, maternal drug intakes like sulfonamides, nitrofurantoin, antimalarials, and the mother can present with an antenatal ultrasound, which has shown some cystic changes in the liver or at the porta. How will the baby present to you? As I said, jaundice beyond 2 weeks of life, along with clay-colored stools and dark-colored urine. Baby may present with bleeding due to vitamin K deficiency, or may have seizures because of hypocalcemia or hypoglycemia due to vitamin D deficiencies. The physical examination, it's most of the time the baby is a well-preserved baby, normal weight and height for the age, usually has hepatosplenomegaly, might have a cardiac murmur because of associated syndromes. And in certain countries like Taiwan, where the incidence of biliary atresia is really high, the mothers are always given an infant stool color cut so that the mother can compare the color of the stools and then approach the doctor as early as possible. Coming to the lab investigations, it includes the basic liver function tests in which you have to, when do you define conjugated hyperbilirubinemia? When the bilirubin levels are more than 2 milligram per deciliter or more than 20% of the total bilirubin. You have to do the newborn screening just to rule out the medical causes of jaundice, which can be cystic fibrosis, hypothyroidism, galactosemia, or other inborn errors of metabolism. Now coming to the most common cause, surgically most common treatable cause of jaundice in the newborns is biliary atresia, which is actually the absence of the bile ducts draining the liver, and it is a pan-ductal involvement. If it is not treated at the earliest, it leads to secondary biliary cirrhosis. There are multiple theories which have been put forward to explain the pathogenesis of biliary atresia. The most common is that there is a viral or the toxic insult which leads to activation of either the natural killer cells or of the CD8, which then initiates the process of epithelial injury and the obstructive pathology. Two most common types of EHBA have been defined. One is the fetal or the syndromic form, which carries a better prognosis than the perinatal or the non-syndromic form, which presents a slightly late as compared to the fetal forms. The most accepted classification of biliary atresia comes from the Japanese group of surgeons, being EHBA being one of the most commonly presented in Japan. So type 1 is the atresia of the CBD, but the proximal ducts are patent. As you can see here, the CBD is atretic. In type 2, either it's the CBD or it's the CHD. Both of them are atretic along with a cyst at the porta. And the type 3 is the complete atresia, which involves the atresia of the cystic duct, common hepatic, common bile duct. So there is complete atresia. This is the commonest form, attributing for almost 90% of the patients. Now, as I've already said, none of the features is pathognomonic for a baby presenting with biliary atresia. The baby is well preserved, normal weight and height, might present with hepatosplenomegaly. And if the patient comes from the syndromic category, the Basem syndrome is the commonest, in which you find multiple anomalies of the spleen, could be polysplenia, double spleen, asplenia, along with cardiac and vascular, the preduodenal portal vein being the commonest presentation. So lab investigations we've already discussed in the previous slides. Apart from the basic workup, we find GGT to be markedly raised in patients of biliary atresia, and you do the other tests to rule out metabolic causes like alpha-1 antitrypsin deficiency, and you look for the thyroid function test. Now, ultrasound, I will not go much into the details. I will be talking just specific to biliary atresia. Two important signs are there. One is the triangular cord sign. It has a diagnostic accuracy of almost 95% with a sensitivity and specificity reaching almost up to 100%. So what is triangular cord sign? It is basically the echogenic anterior wall of the right portal vein with a thickness of more than 4 millimeters, which is visible on the longitudinal scan. The other is the ghost triad, in which you see the gallbladder length to be less than 1.9 centimeters, along with lack of smooth or complete echogenic mucosal lining and irregular contour of the gallbladder. So after the ultrasound, how do we proceed? The next test, if a suspicion is raised on the ultrasound, you go for a HIDA scan. But HIDA scan, you cannot wait for another 1 week for priming of the patient and then doing the HIDA scan, because you do not want that important time to be wasted in patients of biliary atresia. If the patient is like just 2 weeks old or 3 weeks old and you have enough time to investigate, prime the patient with 1 week of phenobarbital and then do the HIDA scan. In the normal HIDA scan, you see there is one hepatic phase and then the enteric phase, whereas in which the radio tracer goes into the intestines. But in patients who have neonatal cholestasis, you see retention of the tracer in the liver even after 24 hours. Now, MRCP, as in the adult patients, MRCP is the gold standard for everything. For biliary atresia patients, we do not want you to do an MRCP unless there is a cyst which is diagnosed at the porta on the ultrasound. And that is to differentiate between the cystic variant of EHBA and the choledochal cyst. Otherwise, you do not do an MRCP in patients of EHBA. In Japan, if duodenal intubation is quite commonly practiced, because if you aspirate bile from the duodenum, it most reliably rules out biliary atresia. The liver biopsy has a diagnostic accuracy of about 80 to 90%. And the histopathological findings include the portal tract inflammation, lymphocyte infiltration, bile ductules, plugging and proliferation, bridging fibrosis, or formation of the microabscesses. So to say, there is no laboratory or radiological study which actually confirms the diagnosis of biliary atresia. All of them require an intraoperative cholangiogram. So when and how to do the peroperative cholangiogram? You have a suspected patient of EHBA, you have done the workup, you go ahead with the laparotomy. If you find a small non-patent fibrotic gallbladder, EHBA is confirmed and you proceed with the definitive surgery. Whereas if you aspirate the gallbladder and you find bile, it does not rule out EHBA, because the type 1 EHBA, where the cystic duct as well as the common hepatic duct are patent, bile will be aspirated. Whereas if you find white bile, it is diagnostic of type 2 or type 3 biliary atresia. So these are the intraoperative cholangiogram pictures. In the first picture, you can see the intrahepatic biliary tree very clearly, the extrahepatic, and the contrast going into the duodenum. Whereas in the second picture, you see the contrast is going into the duodenum, but you cannot visualize the intrahepatic duct. So that is the type 2 biliary atresia. So the stabilization of the baby is very important before taking up the baby for surgery. You have to correct the coagulopathy, correct anemia. The baby should be well hydrated and should be on low dose of antibiotics. And then you proceed for the surgery. There are three main steps of surgery. I will show you the videos later on when I talk about choledochal cyst, because the surgery is almost the same, except that after confirmation of the diagnosis, doing an intraoperative cholangiogram, you dissect and remove the fibrous remnants at the porta. Everything you find there about the biliary tree is all atretic. So you have to remove all that fibrous tissue and then do a portoenterostomy. So these are the intraoperative pictures where you find the gallbladder atretic, the bile duct, common hepatic duct. You do not find anything. In the second picture, there is a cyst, but you cannot find any patent biliary ducts. The same procedure, the Casais procedure, which is the treatment of choice, can be done laparoscopically and has the advantages of good magnification and minimal adhesions at the time of liver transplant, because most of these patients ultimately need liver transplantation. In the postoperative period, the patient has to be given IV antibiotics, kept nil per orally till the child starts passing stools, and low-dose antibiotics in the form of Septran we usually use is given for 6 months to 1 year. And these low-dose antibiotics are given to prevent the cholangitis. UDCA, the use of steroids is very controversial, and along with vitamin A, vitamin D, and MCT oil. The post-operative complications most common complication which we encounter is ascites. And this ascites is to be treated conservatively. You do not need to do anything very aggressively for it, except for giving sodium-free fluids. What is the outcome in patients of biliary atresia? Most of the patients, as I've said, more than 90% of the patients require liver transplant by the age of 10 years. So if you establish a good bile flow, that is seen by the serum bilirubin levels coming down to less than 1.2, you say that there is a good outcome patient. And out of these good outcome patients also, 50% of them will require liver transplant later on. Whereas the ones who are really have complete no bile flow at all, they are the ones categorized into poor and they require liver transplantation at the earliest. So coming to the next most common cause is the choledochal cyst. Choledochal cyst has a female preponderance and is not very common in the Western world, whereas in the Asians, it is quite common with 1 in 1,000 population. So the most important classification was given by Todani, and which is accepted and followed by everyone. Here we categorize the patients into 5 categories. Type 1 is the cystic variant, where you have the complete dilatation of the CBD. Type 2 is the saccular. Type 1C is the fusiform dilatation. Type 2 being the supraduodenal diverticulum. Type 3 is the intraduodenal diverticulum. And type 4 is extrahepatic as well as intrahepatic dilatation. And type 4B is the extrahepatic multiple segmental dilatation. And type 5 being the Caroli's disease, which is the intrahepatic cyst. So the presentation is almost similar like a baby of EHBA, whereas in this we have 2 forms. One is the adult form, in which you find the fusiform dilatation, and they usually do not present with an abdominal lump. It is mainly the cystic variant which presents with the abdominal lump. So the diagnosis protocol remains the same. You do the LFTs, you do an ultrasound, HEDA scan plus minus, CT plus minus, but MRCP is the gold standard for diagnosis of choledochal cyst. So the basic concept remains the same, which is excision of the cyst and separation from the biliary tree. So there's a controversy about hepaticojejunostomy versus hepaticoduodenostomy. Most of the surgeons follow the hepaticojejunostomy as it causes less postoperative reflux or gastritis. So I'll quickly show the steps, major steps. This is the excision of the cyst, where you try to reach up to the lower end of the cyst, almost reach where you can see the tapering of the cyst entering into the duodenum, and you can ligate it with the suture, or you can apply some hemoclips and then divide it distally, mobilize it completely, lift it up from the portal vein without injuring the portal vein at all, and then you divide it at the level of the confluence of the ducts. The second step is preparation of the root limb. The limb is about 15 to 20 centimeters as compared to the adults, where you use a limb of 35 to 40 centimeter. The next step is hepaticojejunostomy. And finally, the jejunojejunostomy is done. So just one line about each of them. Biliary hypoplasia is the hair-like ducts, which can be syndromic as seen in the Alagille syndrome. It could be inspissated bile duct syndrome, which is diagnostic and therapeutic with an intraoperative cholangiogram. Then idiopathic perforation of the CBD is very rarely seen in children. This occurs at the union of the cystic and the common bile ducts. So the take-home messages will be covered by Dr. Saket. So to summarize, you have a baby with jaundice, take good history, perinatal history, do the physical examination, go ahead with liver function test. Ultrasound is this basic investigation. If you suspect a biliary atresia, do a laparoscopy or laparotomy, do an intraoperative cholangiogram. For choledochal cyst, you go ahead with an MRCP. If not, then you look for the viral or the metabolic causes. So ultimately, it is the flow of bile which makes the life flow. Thank you. I'm sorry for taking extra time. It was a big topic, actually 2 big topics which had to be covered in one presentation.
It was very well presented that I don't think there are any doubts about it.
What is the maximum age at which you do a photoendoscopy?
Most of the time, after 6 months of age, we do not do a photoendoscopy. So when we take up the child on the table, we find that the liver is already cirrhotic. So we just take a liver biopsy and we do not go ahead because we do not expect any bile flow in these patients. The liver has already undergone severe cirrhosis. So more than 6 months, we usually do not offer these children photoenterostomy. We tell them to go for liver transplant directly.
At what age would you do just a a liver biopsy and then not do a laparoscopy?
Just do a liver biopsy and not do a laparotomy. Till 6 months of age, it is, as I said, liver biopsy is never diagnostic for biliary atresia. So
to detect whether the child has already developed cirrhosis, so that you don't go for photoendoscopy and you straight away advise a transplant.
actually, the liver biopsy preoperatively is done by our pediatric gastroenterology team. And most of the time, there is severe derangement of the coagulogram by 4 months, 5 months of age. So they do not want to do a liver biopsy. We do it intraoperatively after stabilizing the patient. So usually till 4 months, they do the liver biopsy. After 4 months, they normally do not do the liver biopsy.
And has lap Kasai become a kind of standard?
No, sir, not yet. Not yet. We do the choledochal cyst laparoscopically as well as robot assisted, but we do not do Kasai's laparoscopically.
Thank you.
Thank you so much.
Thank you, chairpersons. For the next session will be the panel discussion on the CBD stone oblique Mirizzi syndrome. For the panelists, I would like to invite Dr. Amit Mathur, sir. He is a professor and head department of gastroenterology, NIMS, Jaipur. Dr. Mahendra Narwaria, he is the chairman, surgical gastroenterology and pediatric surgery at Asian Pediatrics. Dr. Monika Gupta, she is a consultant in GI HPP in minimal invasive surgery at Manipal Hospital, Jaipur. I request Dr. Sundeep Jain for moderating the session. Dr. Sundeep Jain is the director and head GI HPP surgery, Fortis Hospital.
Good morning, all. I'm thankful to Professor Kapoor, sir, for giving me this opportunity. CBD stones are a very common problem and all of us see these patients in some or the other form. And due to paucity of time and with due permission from sir, we are going to limit our discussion on only for the secondary biliary stones and Mirizzi syndrome. How to forward the slides? So for this panel discussion, we have a wonderful panel consisting of Professor Amit Mathur from NIMS University, Dr. Mahendra Narwaria from Ahmedabad, and Dr. Monika Gupta. All of them are well known in their respective areas. So as we all know, the prevalence is around 10 to 20% in symptomatic GB stone patients, and less than 5% of patients where we do not suspect clinically may also have CBD stones. So can you, Dr. Monika, just in short, tell us about the clinical presentation of these patients, the possible presentations?
In CBD patient, presentation is like patient may be having a history of colics, maybe gallbladder related biliary colic or a CBD stone related colic, maybe having previous history of pancreatitis or jaundice. Or in acute presentation, they may have acute pain, vomiting, and fever, maybe striatum may be present in all, not in all.
So absolutely right. Actually, basically, there can be three scenarios. One is symptomatic, like pain or jaundice. Another could be in the form of acute biliary pancreatitis. And third would be presentation with gallstones, where we, before going for cholecystectomy in all patients, do a workup for to see whether there are associated CBD stones. Dr. Amit, can you please tell us about the ultrasound and LFT interpretation with respect to CBD stones?
Yeah, whenever you have a symptomatic gallstones, you tend to do an ultrasound and a liver function test, which are the initial non-invasive investigations that are absolutely mandatory. And there is they have been divided into two. One is that high probability or high risk of having CBD stones, where you have a documentation of the stone on an ultrasound, or you have choledochal, or you have a high bilirubin that is more than 4 along with a dilated CBD. So you are reasonably sure that you are dealing with a CBD stone disease. The other is an intermediate risk, where you have an abnormal LFT with or without a dilated CBD. Now, these are the patients which cause a diagnostic dilemma, and there we require further investigations in the form of EUS, oblique, and MRC.
Sir, just on the LFT part, suppose, I mean, can you just tell us briefly about the interpretation of LFT with respect to CBD stones? Like, what kind of enzyme gives a more probability, or is it only bilirubin, only SAP, or a combination, you know?
Well, if you look at whatever we have data about that, the sensitivity and specificity of each individual investigations with bilirubin, OCPT, or an alkaline phosphatase is not really very high. It's about 70 to 80%. So they need to be supportive of each other. So bilirubin is around 70 to 80%. Same is about alkaline phosphatase. But you need to look at the entire scenario, the clinical profile along with the ultrasound, and to really decide whether the patient has a CBD stone or not.
Dr. Mahendra, can you please elaborate about the role of MRCP and EUS for this disease, and conditions favoring one over the other? I mean, in which situation you would prefer EUS over MRCP and vice versa?
MRCP is must for any, whenever we have diagnosis of CBD stone, I think we should have a roadmap, and we should try to rule out the other pathologies which are responsible. So MRCP must, EUS is only when you are having some diagnostic dilemma, or the stones are very, very small.
Yes.
Can I add on to this?
Yeah.
In fact, MRCP and EUS, both of them have an equivalent sensitivity and specificity. In fact, the sensitivity of EUS is better as compared to MRCP. Now here, actually, it all depends upon one, the availability. A lot of these centers don't have an EUS. Then the expertise, whether the doctors are experienced enough to pick up CBD stones, and also the adverse events. If you see that MRCP is basically a non-invasive investigation. Vis-a-vis EUS, you have the risk of anesthesia and all. But again, MRCP, you can pick up, delineate the entire biliary tract, and you can also pick up CBD stones, especially when you have an abnormal anatomy. So there, I mean, both of them, they complement each other, but they have a reasonably good sensitivity and sense. But the advantage is, when you have a high probability of having CBD stones, doing an EUS prior to ERCP is very useful. I mean, you can straight away go in for an ERCP. So there, EUS has a definite advantage.
Absolutely. And in fact, there are situations where one or the other has a significant edge over the other. Like for EUS over MRCP, like patient having metallic implants where MRCP is contraindicated, morbid obesity, or patient is claustrophobia for MRCP. And in fact, MRCP over EUS, as you have already mentioned, if you have to delineate possibility of intrahepatic stones, for example, and minimal invasive nature of the MRCP. And one of the good advantages of MRCP is also that it can be, reviewed by multiple specialists later on also. So classification of likelihood of CBD stones into low, intermediate, and high already mentioned by Dr. Amit. And low when the LFTs and ultrasound are normal. Intermediate when CBD dilatation is there on ultrasound with normal LFT, or abnormal LFT and normal bile duct. And high likelihood when CBD stone is seen in ultrasound, choledochal, duct dilatation, and jaundice in patients with history of GB stones. Dr. Monika, would you like to add something here?
According to PGC guidelines and my suspicion, the percentage of finding us in the surgery or during the procedure, 80 to 90%. And in moderate or intermediate category, it's approximately 60%. And in low, it's very less. So can proceed directly.
Absolutely. So treatment options for CBD stones includes endoscopic, surgical, which may be laparoscopic or open, with intraoperative cholangiogram or IOUS, and radiological. Here, when I say surgical and treatment options, I am talking about the first choice of modality of treatment. I'm not talking of patients which are not amenable to endoscopic modalities. So endoscopic management of CBD stones, Dr. Amit, can you please elaborate on the success rates, complications, and timing, especially whether before surgery, along with surgery or after surgery, which would be the right thing?
Yeah, actually, if you look at the success rate when you're doing just enterotomies and ERCPs, it was reported to around 80 to 90%. But with the coming of the sphincteroplasties, that is the balloon dilatation, the success rate has gone beyond 95%. In fact, honestly, if we take up 100, we hardly are referring the patients for surgery in less than 1 to 2%. Most of them are amenable to the various modalities, and if the patient is affording, then obviously we have got a spyglass cholangioscope to look into the difficulties of those. So the success rate has really gone high. And if you look at the complications, obviously what has been reported is that complications per se of ERCP is about 8 to 9%, of which the majority, about 5 to 6%, is because of pancreatitis, and about approximately 2 to 3% is bleed, and rarely you might perforate. Now, regarding the timing, I mean, obviously, practically what we prefer is before a lab, that is a sequential procedure is the ideal, and doing a lab within 2 weeks is what is desired. But at times when you find an intra-op during cholecystectomy, you find a CBD stone. That time also what has been seen in literature is it is as comparable to a sequential one. You can do a rendezvous ERCP at the time of doing in lab coli. Regarding post-op, also if you are still strongly suspecting, or you picked up a CBD stone done immediately, I think the results are good. So the timing best is a sequential one, but even the intra-op and post-op, you can manage the stones.
Can we have the surgeons practice insight what they practice regarding timing of ERCP and cholecystectomy in your own practice?
ERCP first,
And after how many hours or days you would?
you observe for 24 hours for the pancreatitis. If there is no sign symptoms or still pancreatitis, we go ahead with that.
Dr. Monika, same for you?
MRCP, when deranged LFT or any suspicion, then followed by ERCP. And if it's all uncomplicated procedure, then we'll say admission police. If it's a complicated procedure, pancreatitis, we can give up.
Yeah, of course.
I think the idea is doing it within the same hospital.
Same hospitalization.
But a lot of surgeons are still apprehensive of doing it in the same but the carry-on message should be done in the same.
But this is very important, as you have mentioned, that a gap of few hours, at least 24 hours, to rule out whether there is some inadvertent pancreatitis associated with this. Because sometimes what happens, there are few instances where both the procedures were done on the same day, and later on, because of unfortunate episode of pancreatitis, it was really difficult to manage those patients. So regarding surgical management of CBD stones, again, when I say surgical management, I mean the selection of surgery as the primary modality of treatment of CBD stones over ERCP. So what are the indications, timings, and the type of investigations on table you would like to have if you are going for a primary surgical CBD exploration, Dr. Monika? And what is your practice?
Pre-operative CBD exploration.
No, I mean to say whether you in your practice, I mean, first, as per the literature, the indications, timing of lab or open CBD exploration selected as the primary modality of treatment of CBD stone over ERCP.
I think nowadays ERCP has so advanced that even they can remove. Plus the cholangioscope, they have the mother baby scope. So they are actually different. Operative case.
At 10:15, 10:30. I told 10 yesterday, but I'll go 10.
Not more than that. So for directly selecting for laparoscopic or open exploration, I think we need to have a multi-specialty again. And if the patient is unfit or there is a diverticulum or anything which interferes with technical possibility of ERCP, then direct laparoscopic or open GE exploration can be.
So basically, this is what we all practice. That we are in our practice. Gold standard is ERCP followed by laparoscopic cholecystectomy. But when we talk of evidence-based practices, the equally effective treatment is lap CBD exploration, irrespective of size, and the results are equally good. And in fact, there is one, as per the literature, one evidence which shows that the laparoscopic CBD exploration in terms of hospital stay has an edge over ERCP followed by laparoscopic cholecystectomy. In terms of morbidity and overall outcome and complications, the results are same.
But obviously, if you give the choice to the patient, you would definitely prefer a simpler non-invasive procedure like ERCP.
Sir, actually, it's very difficult to interpret in that way because, you know, if you really start doing lab CBD exploration which in some of the centers are not very large in number who are doing primary CBD exploration laparoscopically, their results are very good. And actually, ultimately, you see, you are doing one procedure to the patient. Patient might surprise you by selecting lab CBD exploration over ERCP followed by lap chole because it avoids two procedures, two GAs, same GA, single procedure, less hospitalization. So it's difficult to answer actually.
That's a debate actually.
It's a debate actually.
I'm outnumbered actually.
I agree with you, sir.
Not only is altered, this is post-gastric bypass, post-distal.
I'm coming to that, sir. It's still on the cards. And we are glad that you are one of the panelists and you are the most appropriate person to answer that. And one more thing, if we are selecting lab CBD exploration over ERCP, we have to have intraoperative cholangiogram or intraoperative ultrasound before we intervene for CBD exploration surgically. So surgical CBD exploration versus endoscopic clearance, I have already mentioned the advantage is only in terms of shorter hospital stay in favor of lab CBD exploration. Now coming to difficult CBD stones. So there is a definition of difficult CBD stone, which means that which is not amenable to endoscopic management or laparoscopic CBD exploration. So Dr. Monika, can you enlighten us about the modalities of difficult CBD stone for its treatment?
Those which come for surgery are either the primary CBD stones made along the forward stent or having a biliary stasis like in the around the ampulla. There is a flow of bile restricted. So primary stones are mostly here. So in primary stones,
Sure. We are here only limiting our topic to secondary CBD stones. So let us stick to that. In secondary CBD stones means which are originating from the gallbladder. In those, in your what are the modalities of treatment for difficult means? Dr. Amit has tried. It was so difficult with all the armamentarium, endoscopy not possible. Dr. Narwaria, the best laparoscopic surgeon, has also said that it is not going to be operated, not feasible laparoscopically. Then what is the treatment option for that?
Actually, difficult CBD stone doesn't mean that it is not managed, it cannot be managed by ERCP. Difficult CBD stone, there is a definition for that.
Sir, it's in literature. No, it's not about size, sir, nowadays, because the size it's losing its meaning actually, because it is dependent on the armamentarium you have got with you, that which size is amenable to endoscopic treatment or not. So if we consider a situation where everything is available in terms of technology and in terms of expertise, and if the definition which is mentioned in literature is difficult CBD stone, which is not amenable to all kinds of endoscopic interventions and laparoscopy. So it's the definition which I had found. Anyways, the meaning is, what I want to ask is that when would you consider the open surgical CBD exploration?
technically difficult for ERCP.
Yeah.
Surgical,
So what are your modalities of treatment for those difficult stones?
Biliary and laparoscopy. There are large and multiple stones which are difficult to clear because every center doesn't have choledochal, choledochal. So that is a problem. We need to ensure the clearance. That is my criteria for open versus lab. If in lab I cannot ensure clearance without harming the patient, then I will prefer open. So these are the criteria. In open, I think very rarely the CBD stones are very difficult.
So
One example I will give for difficult CBD stone is like infected and ampulla. A faceted stone infected ampulla which may need a sphincterotomy, open sphincterotomy and there was one case.
So just to clear once more that when I say difficult, I mean the situation where every endoscopic procedure has failed, tried and failed, or preoperative assessment shows that it is not possible, and lap is also not possible. So for these patients, there are only two options remaining: percutaneous methods and open CBD exploration. It may be multiple stones, enumerable stones, where you need to have a biliary enteric drainage also. In rarest of the rare cases, as Dr. Amit has also already mentioned, it's now becoming a rarity every passing year to get a CBD stone treated by surgeons. Sir, Dr. Amit, please tell us about the US advantages and indications of US guided CBD biliary drainage for CBD stones. Is it a mandatory thing, or it needs to be applied selectively?
No. Actually, when we have already classified as high risk and when you've already documented a CBD stone, we really don't need to go in the US. Only when there is a probability where we have not been able to document, or where MRCP is not available, and we need to be very sure that we have to do an ERCP. A US prior to ERCP is very helpful. In fact, the literature says that they have avoided ERCP in almost more than 40 to 50% of cases when they found it a negative US. So I mean US prior to ERCP, when you don't have a definitive evidence of CBD stones or an ultrasound, or just an abnormal LFT is definitely used. It is that situation where you do in US.
And another, in your practice, how common is it? Like one of the indication of US mentioned is that when the cannulation is difficult, then you take help of US to puncture the, either transduodenal or puncture of the CBD for,
Actually, honestly, for that, you require a very good, highly trained endosonologist, the dedicated endosonologist. Usually in about 6 to 7 out of 10 of the centers, you really don't have it. You do an endosonography for just taking FNACs and diagnosis, and for that you require really good expertise. So for cannulation, honestly, we have not been using it, and over a period of time with the expertise, the failure of cannulation also goes down. So that number is also very less. But US is definitely not used. But again, if you have a very good endocrinologist, that's not a bad option.
So coming to stenting as the only treatment option for CBD stones, what are the indications? And if at all you use that, what would be the frequency of stent change?
Yeah,
Again,
in,
to Dr.
what happens is at times when you have multiple stones or an impacted stone or a very large stone, which is not immediately amenable to the endoscopic removal, we put in a stent. And when we come back, say what has been said.
No, sir. I think I have not able to communicate properly. Stenting as the sole treatment, where you are not contemplating anything other than stenting. What would be the indication?
That is only a limited group of population, that is very old people who cannot be subjected to surgery, or have or those who have got such debilitating illnesses where the life expectancy is very low.
Exactly.
So that is the only place where they have been.
So very limited indication. And the stent frequency, it has been proved that the stent change on demand has got a much higher rate of cholangitis and mortality in comparison to elective stent change every 3 months in these patients. So coming to treatment of asymptomatic CBD stones in patients with gallbladder stones.
According to literature, asymptomatic stones exist. A few percentage may not be symptomatic, but they require treatment. They cannot be that like an asymptomatic stone. They need treatment, because in long run they may create complications, they may slow down, create convertitis.
And this applies to even after cholecystectomy, I think. So you are absolutely right, and we have now enough evidence to suggest and propagate this, that even if CBD stone is asymptomatic, it can be life-threatening, and irrespective of size, it needs to be removed. We have discussed this management of CBD stones without gallbladder stones. So recurrent CBD stones are seen in around 20% of patients with residual gallbladder stones and 5 to 10% in patients with empty gallbladder. No, sorry, I have missed the slide. So coming to the stone extraction in patients with altered anatomy, we have two kinds of altered anatomy in our patients. One is because of Billroth 2 gastrectomy and another is because of Roux by gastric bypass. So Dr. Narwaria, what are your, what do you say when you have to do CBD stone, have a patient with CBD stones with history of either of these procedures?
Just to add the previous slide also, this remnant cause, we have remnant cystic facts also, which can cause recurrent is from the same thing I have seen.
Yeah, it's quite a common, not very unusual thing.
And in Biliary gastric bypass and cystic stone, the access is nephroendoscopic approach, wherein you can put a trocar into the remnant stomach, which is 15 millimeter. You can do ERCP through that. We have done in two patients and it will be good success. Only one person when we did this and after that we see a lot of CBD stone. Then I will do biliary anastomosis. So it's really cause that was.
So do you think that this approach of endoscopic approach in obese patients, they have a higher complication rate?
I think in this food surgical anesthesia, the key is that we should use CO2 as an supplement, not the air, because that will remain suspended for longer period of time. And number two, you clean both the limbs so that the gas will not be filling the space. So all the volumes should be empty, but we have
But
space to operate.
post procedure complications are not significantly high. So this is about CBD stones. Coming to the Mirizzi syndrome, the incidence is around 1%, and the why Mirizzi syndrome is an area of interest despite its incidence being around 1% only, because it's difficult to identify pre-operatively. It mimics cancer sometime, represents a precancerous condition, and it increases the risk of bile duct injury during cholecystectomy if we are not careful. So, Dr. Monika, can you please tell us about the clinical presentation, or when would you be suspecting Mirizzi syndrome pre-operatively in any of your patients?
But clinically, they are not much different than CBD stone or gallstone patients. But if LFT is present, then a further workup can lead to diagnosis of Mirizzi syndrome, like stone impacted at the neck, or invading the CHD and causing the bilobar IHDF. So clinical presentation is like CBD stones, and for imaging, I think MRCP should be done with LFT given, which is also helpful in.
So the only difference between Mirizzi and other CBD stone is that the higher probability of getting a CT scan done, because in some patients we may have a doubt of malignancy. Preoperative biliary decompression, Dr. Amit, what do you say about the indication of?
ERCP has been very useful in the disease, especially when we didn't have an RCP. That was the modality of diagnosing the disease, and whenever we have these patients, we do a perimeter compression. And now with the advent of cholangioscopy, there is become a big therapeutic value. A lot of patients of Mirizzi can be dealt with cholangioscopy and with laser. So the cholangioscopy has become an added tool for doing a therapeutic intervention in these.
Yeah, basically the CBD stone part of the Mirizzi can be tackled. So Mirizzi syndrome by and large is a surgical disease. You may have tackled the CBD stone part of that disease endoscopically. So there are multiple treatment options, surgical options, and different patients may require different kind of procedures. So Dr. Monika and Dr. Narwaria, both of you, please kindly tell us about in very brief about all these procedures, when to do what.
For type, like for the classification, one or two variety is more important. Like one is like only pressure, two is like having fistula, or 2, 3, 4, you can say. And the fistula is maybe 1/3 of the CHD is involved with the stone, right? Eroded. And in 3, it's 2/3 and more than 2/3. So depending on that, one must be aware of this entirety, keep reading about it, and also not burn their hands in this type of disease, because once you remove the stone.
So what would be your, because of positive time I am interrupting, sorry, what would be your choice of when would you select laparoscopic cholecystectomy in Mirizzi syndrome?
One variety laparoscopic the laparoscopic cholecystectomy with stone extraction is sufficient, but good cholecystectomy and suture laparoscopy.
So let us go one by one. So laparoscopic cholecystectomy, you are recommending for type 1 Mirizzi. Dr. Narwaria, retrograde cholecystectomy and subtotal cholecystectomy, what would be the, when would you select these procedures in Mirizzi syndrome?
We get a plan to do from the country and what will be the one to support. I think most of these courses are using the laparoscopic. I don't think so many ones are. And this is good. This is good. Difference are on the-
And Dr. Monika, about ruined by hepaticojejunostomy, would you consider in any of your patients of Mirizzi's?
Yeah, that is right, and pre-operative dilatation of the biliary system here. But with the cholecystectomy, I'll recommend that prefer G2 or endoscopic stenting also because the fistula may not heal because of presence of stricture. Second thing, with the problem which you encounter, there is a stricture like a CSD, which is not visible in view of imaging because of the pressure of the stone. So that may lead to interference.
I think- Yeah,
Gives time to Saket.
Yeah. So that was the last slide, sir. So only one thing I want to add is that intraoperatively, one good indicator is when you open the infundibulum and remove the stone and there is a sudden gush of bile, that may be an indicator of that we are dealing with Mirizzi syndrome. Thank you very much.
I think the panelists stay because his questions will be addressed to you. Sundeep, आप इधर आओ.
Good morning, and I am very grateful to organizers of IASGO PG course and especially Dr. V.K. Kapoor sir for having me here. So I'll be concluding the sessions with a few questions and take-home messages. Easy questions, I think all students would be able to answer it after such thorough discussion and a lecture. So without wasting much time, I'll come to the question number 1. So a 5-year-old child presented with jaundice and lump in the right upper quadrant abdomen. It was noticed by her mother since 1 month. This is the MRCP image. So what is the most likely diagnosis in this patient? Is it choledochal lithiasis, biliary atresia, choledochal cyst, or Mirizzi syndrome? Choledochal cyst, right? So coming to the question number 2. A 55-year-old gentleman presented in emergency with disorientation. BP recorded was 74/40 mm of Hg. He had jaundice, fever with chills, and pain abdomen for 3 days. Ultrasound done outside had shown gallbladder stones, intrahepatic biliary duct dilatation. CBD was of 14 mm, but the lower end of the CBD was obscured by gas. The blood parameters were like leukocytosis 21,000, predominantly neutrophils. Serum lipase was elevated, 95 unit per liter per ml per liter. Sorry, and serum bilirubin total was 6.6, direct was 5.4, alkaline phosphatase 550, AST ALT elevated 255 218. So what is the most likely diagnosis in this patient? Is it acute cholecystitis, severe cholangitis, acute gallstone pancreatitis, or acute hepatitis? So it is typical of Charcot triad, pentad in this patient. Patient having hypotension, disorientation, along with jaundice, pain, and fever. So this patient is having severe cholangitis. Coming to the third question, which of these statement is correct? ERCP is the treatment of choice for intrahepatic stones. Mirizzi syndrome may mimic gallbladder cancer. Primary CBD stones are formed inside the gallbladder, and T-tubes should be removed after day 3 or 5 of CBD exploration. We have just discussed this point.
The panelists can also make comments in between. B is the right answer.
Right.
That's
So,
what we discussed.
yeah, we had just discussed that Mirizzi syndrome may mimic gallbladder cancer, especially which arises from the neck of the gallbladder. So coming to the take-home messages. So as discussed in the lecture, biliary atresia is one of the most common cause of surgically treatable cause of obstructive jaundice in newborn. It is characterized by conjugated hyperbilirubinemia, atretic gallbladder, and triangular cord sign on gallbladder, and on HIDA, there is no excretion of radionucleotide in the bowel. Surgery before 6 weeks is associated with improved outcomes, and after 6 months, surgery is not feasible in most of the cases. Roux-en-Y botulisectomy, which is known as Kasai procedure, is the procedure of choice. Still, 15 to 30% of patients require early liver transplantations. Choledochal cyst is characterized by abnormal dilatation of intrahepatic, extrahepatic, or both of the bile ducts. It is classified, classical triad is of pain, jaundice, and lump abdomen, but all these together are present in less than 50% of cases. MRCP is the diagnostic modality of choice, and the treatment is excision of the choledochal cyst with Roux-en-Y hepatocytostomy reconstruction. And coming to the last slide, ultrasound and MRCP are the most useful modality for diagnosing CBD stones. US still has some role in some cases, especially before going for ERCP. Most of the CBD stones can now be managed with ERCP. The indication of surgery is becoming less and less. Still, surgery is indicated where there are intrahepatic stones, large impacted stones, stones associated with the biliary stricture, and ERCP is not feasible because of altered anatomy. The treatment of Mirizzi syndrome type 1, as said, was cholecystectomy, and type 3, type 4 usually requires subtotal cholecystectomy or Roux-en-Y hepatocytostomy because CBD is totally involved in the disease process. Thank you.
Can you do the last question which you were? Yeah, I'll request the panelists because one has been answered. A, C, and D, you can elaborate for the students why ERCP is not the treatment of choice for the intrahepatic stones. Why primarily CBD stones? Why is the definition that they are not into it? But what is the content? Why is it not to be done?
No, I can take up the first one.
Yes, you can take the first one. I can take the three.
Obviously, the diameter of the intrahepatic biliary reticulocyst is very less, and usually it is very difficult to manipulate the basket and all, and the success rate of removing most of the intrahepatic stone is very less. Unless and until you have a cholangioscope, where now you have an improvement in the removal of intrahepatic. So just ERCP, a therapeutic ERCP without a cholangioscope is not useful, but cholangioscopy has opened an option for removal of intrahepatic stones, but not all of them. If you have multiple intrahepatic stones, obviously surgery becomes a treatment. But 1 or 2 intrahepatic cholangioscopy, the patient can afford the good option.
Then what is the option with multiple intrahepatic stones?
I mean,
Maybe surgeon can test.
Multiple intrahepatic stones, if we are not able to remove them intraoperatively via the choledochal, we can access with the help of the good jaundice, and with flushing we can remove. But maybe if there are impacted stones, they may be difficult so ultrasound role comes. So ultrasound will also be available if there are multiple studied plus biliary drainage procedures.
Biliary drainage with access loop is one, which is because you can do a endoscopy and the stones and it's out.
We want to add something.
I think when we surgeons have to tackle an intrahepatic stone case, then we must have a facility of intraoperative cholangioscopy. And if we don't have that, we should refer that cat to the center. Whatever we may do with access loop or whatever, the best chance is that at the time of surgery, we must be able to remove as much stones as possible. And that can only be possible with the assistance of intraoperative cholangioscopy.
I think one more very important point. I think there was what Dr. Sundeep said. There are multiple strictures in a particular area that can be restricted also. It's not only that you believe in truth. You have to ensure that most of these stones are 90% more than 90% stones are out on the table. And then you make a big anastomosis. That is also very important.
And access to grow is controversial. But on-table removal of stone by using all the modalities is available and colonoscopy is must. And if there is a posterior sector is involved and there is a stricture, then what will you do? So you go and do a resect that segment also. So these are the different options available to my mind.
Absolutely, sir. In fact, we must have a investigation profile where we would be able to diagnose before taking that patient to table, that patient is having intraoperative stone along with strictures. Because in that case, the surgical modality will change significantly and it would be very difficult to contemplate liver resection on table. We must have had, yeah. No, I'm elaborating your points. I'm elaborating your point. So it is very important.
Point D also, you can take that.
See, should I address the point C?
I can see you are, see the obvious baby students, no white primary CV students.
YouTube actually form fistula is not there, a fibrous tract is not there before 6 weeks. So standard practice in my practice, it's like more than 1 month or 6 weeks. I don't really.
After 2 weeks. 2 weeks, Sundeep.
Actually, we have to understand that the material of T-tube which from which it is made decides the maturity of maturity of tract, whether it's of latex or PVC. Nowadays, we get most of the T-tubes available are of PVC. Therefore, we take 3 to 4 weeks to remove them because tract, it is so inert that it does not elicit inflammatory reaction and fibrosis. So we need to remove after 4 weeks. But previously, we used to get canary yellow T-tubes made of latex. Those T-tubes could be removed within 10 days also, 7 to 10 days, because they elicit very strong inflammatory reaction and fibrosis and forms tract very fast.
Take the question if there are any questions on the chat from the online. We have given answers to the questions.
I have a comment actually. We have not discussed the importance of GBD. I think it is also equally important. It is for the benefit of the residents. In LFT, we generally tend to forget doing GBT, especially when we are evaluating CBD stones. And knowing that it is more specific and obviously it is more complementary to ALV, it is equally important that we should evaluate GBT. And second thing, sir, what according to you are the absolute indications for US in a patient with CBD stones?
There is no absolute indication. Only is when you have a doubt about the stone being there, because lower end CBD stones usually are missed sometimes from MRCP. But when you are strongly clinically suspecting you have an abnormal LFT and you are planning, you have to decide whether you have to go in for a therapeutic ERCP. That is where it gives an advantage. Right when ERCP you do in the US and really delineate this.
Whatever you said.
The other is you can also decide about the modality of treatment. I mean, what exactly you plan to do in a therapeutic ERCP. You have delineated the anatomy and what is the type of sizes.
Regarding LFT, actually, the literature puts very less importance on GTD and LP, but in practice, we put very much importance on that. I think I have got benefited by using GTD and ALP strict testing and strict follow-up of in the pre-op setting. And because in our center, capacity is available or a good sonologist is available, we tend to recheck the degree status. So maybe more literature.
Doesn't really talk about GTD.
So one thing I want to specify on the question of LFT, many times we see patients or before lab poly have a very limited kind of LFT like OTPT or bilirubin. So we must develop the practice of asking for full LFT in every case where we are planning laparoscopic polycystic.
You can answer
Yes.
that and then we will.
Yeah, there is one question, how the size of T-tubes would be decided at the time of CBD exploration? Which size to insert?
So the
I think 14 frames,
actually the size basically depends on the size of the CBD, what size of CBD you are dealing with to remove stones. And I am sure all of us, the surgeons, must have used right from 8 French to 14 French. It never been a situation where you need to go beyond 14, because in that case, rather than T2, probably you need a biliary enteric anastomosis. So anything between 8 to 14, both the extremes are rare. Majority of them would be good to use 12 French T2.
there is a resistance on the CBD and stenting is needed, it will interfere in that stenting.
Well, my last question to the panelists and the moderator, sir, regarding as we are getting day-to-day activity and day-to-day patients having CBD stone, which can be categorized single stone or multiple stone. The CBD size is around 10 to 12 mm. Should we investigate these patients further or we directly subject to these patients to ERC? Single stone or multiple stone? Should we investigate these patients with imaging?
We need to further investigate.
As we are getting directly ERC.
If you are taking it up for laparoscopic CBD expert.
No.
No numbers.
Question is 10 to 12 mm CBD having single stone or multiple stone. Should we investigate this patient with MRCP or directly should
I think let me elaborate on Anand's question. It clears that whenever patient has a CBD stone and you get a medical gastro opinion, the opinion usually asks you, we like to have a MR before going ER. Do you before doing ERCP? Do you believe in the same?
Honestly.
We have Dr. Saraswat who says that he doesn't need it. We have other colleagues who say they always need it. What is your exception was also is fine. Listen, we have we can also give his opinion. We have three people they get if you have CBD strong or anything, no need
These are not good methods.
So
that I think
only when there is a doubt that we can take a lens type of CBD strong with all the available modalities.
Sorry, sir, one difference of opinion is here. Now the diameter of the CBD is more than 12 mm, single stone with normal alkaline phosphatase with raised alkaline phosphatase. Should we investigate with MRC or not?
No investigation.
Because the
Clear
thing
duct,
is come.
need to clear the duct, then you may have a need to investigate or you find a stricture.
Sir, the question comes here, the diameter of the CBD is 16 mm, stone diameter is 10 mm. Should we investigate this?
No.
When
Because
the
the
stone-
diagnosis-
A stone is mobile, it moves up and down. Once it is stuck at the lower end, you'll get a 15-16 millimeter bile duct. Once it disimpacts, it goes up, it is 12 millimeters, and the duct is dilated. I don't think that observation justifies the need for a second test by and large. Unless you have other reason to suspect, say, a lower end tumor or a stricture or something on clinical ground, then you might ask for a separate test.
Absolutely.
But pure CBD stone, I don't think you need further.
Thank you, sir.
Thank you.
Thank you, Chairperson.